go to Dr. Bai, who is speaking on endovascular total occlusion of cerebral AVMs.
Thank you.
It's Dr. Bai from Henan Provincial People's Hospital, one of the skillful endovascular surgeons.
Can you see my screen? Can you see my screen?
Yes. Yes.
Okay. Okay.
You're not on yet.
Yeah. Okay.
There you go. Perfect.
Okay, it's my honor to be here to share my experience with embolization of bAVM. I came from the Professor Heni's team, but I'm not a neurosurgeon. I'm a neurointerventionalist. During the working of the past days, we have competition with neurosurgeons, and we have collaboration as well. So today my topic is just focused on the total embolization of the bAVM. Yes, I perform procedures with total embolization of AVM and pre-surgical embolization as well. Firstly, I'm claiming my principle about this topic. First is the total occlusion in one session remains the goal of my endovascular embolization, because the partial embolization cannot benefit the patient, sometimes even increase the risk of hemorrhage. So that's what's verified by several clinical trials. The second, tailored strategy on embolization is tailored strategy depending on the individual angio architecture. So the third, the AVM, arteriovenous malformation, in other words, in my mind, means arterial and venous management. The proper management of the artery makes your operation safe. Meanwhile, proper management of the venous makes your operation eventually effective. So the following is some cases, a different location and a different angio architecture. So I gave them the individual embolization strategy. So this case is from a cortex to the deep location, from the superior anterior to the cerebellum. So just to show you some cases. This is parie-occipital AVM, is ruptured one. So the DSA reveals its angio architecture. It's the left internal carotid artery injection. You can see the very diffusive nidus. And the nidus is shown better through the vertebral artery injection. You can see the yellow arrow indicates the aneurysm structure, aneurysm-like structure. And the blue arrow indicates the draining vein, the irregular shape. So as for the AVM characteristics, is as following: is ruptured, and diffusive, and irregular shape. This nidus has countless small caliber feeders and is a slow flow shunt. So I provide the strategy like that. I perform super selective catheterization, and through the catheter, I inject ethanol. to obliterate the nidus. So this is the result. Under the neurophysiological monitoring, I performed the external obliteration. You can see after my obliteration, a little bit remnant is still feeling, was still feeling. As for the follow-up, from 4 months later, the internal carotid artery injection revealed the total permanent cure by my embolization. So this 4 months later, the post-operative MRI scan showed a little bit something like a scar over here. The patient has no neurological deficit. This one is parietal AVM. This is a rupture too. So in CT angio showed the the nidus is supplied by multiple pile branches from ACA and MC as well. So this is the angio, the AP view and the lateral view of right internal carotid artery injection. So as for the IVM characteristics, this is the ruptured one. Multiple feeders from ACA and MCA pile branches. And for this patient, he has a relatively compact nidus. What's more, the nidus has an exclusive draining vein collector to superior sagittal sinus. So I gave the tailored strategy. The arterial, first of all, arterial inflow arrest. Afterwards, I inject onyx via venous approach. This is following. This is the outcome. So this cone mass is used to decrease the arterial inflow. This cone mass is used for a pressure cooker technique. I navigate the macro wire and the macro caster through the sagittal sinus to the deep location, the nidus. So this is control angio right after embolization. You can see the total experience, total despair of the nidus. So the subsequent follow-up revealed the durability of my embolization. So you can say it's a permanent cure of this vessel malformation. So as for the basal ganglia AVM, is a very challenging. It's a very challenging type of either for endovascular or open surgery. So this is rupture one. There is a hematoma burst into the ventricle. So as for the DSA, you can see the nidus. It is supplied by multiple perforators and with exclusive deep draining vein. So as for the characteristics, it's rupture one, perforators filling nidus, and the patient has exclusive deep draining vein. So the strategy is quite clear. So under arresting of arterial inflow, I inject onyx via venous approach like that. So I don't know how many neurointerventionalists in this webinar. So I don't know whether I need to introduce more about the technique nuances. So this balloon I deployed here inside the MCA to achieve decrease of the arterial inflow. Meanwhile, I perform the onyx from the draining vein. So this control angiogram right after embolization is occlusion 100% like you saw. So this is a follow-up several months later, reveals the permanent occlusion of the whole nidus. So besides supratentorial AVM, I perform some AVM located in the infratentorial. So this is the rupture one. AVM is a very small size. And this is a ruptured aneurysm, is a flow-related aneurysm ruptured. Is a rotation angiogram shows the relationship of the aneurysm and the nidus. So this AVM has characteristics as following: the rupture site of the flow-related aneurysm, and the nidus is supplied by pica distal branches, and the nidus is quite a small size one. The strategy is as following: I use S-node obliteration for the nidus. Afterwards, a calling of the aneurysm. This is a procedure I performed. So first, I use S-node to obliterate the nidus. You can say the early filling of the draining vein doesn't appear anymore. After that, I withdraw my microcaster into the aneurysm sac and put some coil to occlude the aneurysm and keep the parent artery patency. So this control angio right after embolization, you can see the parent artery is still patent, and the AVM nidus disappear. The follow-up revealed a good outcome, like these AP view and lateral view. And this is the case more AVM located on the cerebellum ponti. This is a 27-year-old male who presented with trigeminal pain, which is intractable for conservative treatment. The angio revealed the cause of the trigeminal pain. There is a AVM like that. You can say the AVM is supplied by, yes, firstly is unruptured one. This nidus is supplied by multiple feeding from superior cerebellar artery, ACA, and pica. So meanwhile, the nidus is a relative compact one. So my strategy is arterial inflow decrease by main feed occlusion, except one. I advertently left one big feeder, through which I inject onyx with help of high pressure cook technique. So First, I occlude the main feeder by injection of globulin from pica and then from ACA. And eventually, I navigate a microcatheter inside the branch of superior cerebellar artery. I made a high pressure Cook technique. You can very clear, and then I put onyx. I inject onyx, and I achieved the cure. The total cure of the AVM nidus. You can see the country angio right after embolization is very clear, 100%. It is glucosed. As for the complication and the risk, including two sides. One is the procedure associated ischemia caused by occlusion of certain angiographically invisible arteries, or a venous congestion caused by draining vein occlusion. So both of the complications can be prevented by identifying the exact location where you inject the glue. You can identify the location by the super selective angiography through microcatheter, or you can identify the exact location of the draining vein where you can sacrifice the venous collector through the later venous phase of angiogram. So the other kind of complication is material associated, such as microcatheter detent, SNO-induced edema. So both of them now could be resolved by distal detachable catheter, like Apollo, a product from Medtronic company. And the SNO-induced edema can be relieved by prophylaxis use of cortex steroids. So I choose some indication for total embolization in one session. So the total embolization in one session is not feasible for all of bAVM. It's just for selected growth. So for me, I think it's ruptured AVM. You can choose some superficial location by arterial approach. For deep located one, venous approach could be considerable. For ruptured AVM, I performed embolization for the following types. One is remnant left after other treatment. For some AVM with high risk characteristics, I make all my effort to perform my embolization in one session. For some small compact lesion, with each approach, either arterial or venous approach, the total embolization is not difficult. So this is my take-home message. As comparison with the arterial feeders, the draining vein and the draining pattern is more crucial for your treatment and for the patient prognosis. This is the technical nuances. So for a good embolization for bAVM, high pressure cook technique is mandatory. And the caster with the detachable tip is very helpful. The mainstream, the most common used embolic agent for me is onyx instead of glucose, instead of gluburan or something. When you want to use the ethanol to obliterate bAVM, the balloon caster to achieve an inflow arrest, it is often helpful. Yes, for some bAVM of eloquence, real-time monitoring and the water test is mandatory. So please always bear in your mind the target of embolization is numerous fistulas and associated primary draining veins. What's the primary draining veins? Let me show you by this video. So this is the ruptured, it's a ruptured AVM. You can see. Huh? Okay. You can see the feeder is mainly supplied by anterior choroidal artery. You can see the aneurysm-like. So in the venous phase, it's not fluent.
Flowing smoothly, right?
Yeah, it's delayed. It's somewhat delayed.
You can try it again if you want. Try to start it again.
Okay. So you can say they are early filling of the small veins. 1, 2, 3. This is the aneurysm-like structure. So this is venous character, exclusive. So if you can embolize, this is primary draining vein, either by arterial approach or venous approach, you will win the game. That's my presentation. Thank you all. Thank you, translator.
Okay, thank you very much, Dr. Bai. Let me get you off the screen share there so you can entertain some questions or comments here. You can move your camera up a little bit. We can only see the bottom part of your head.
And because my camera is located on my keyboard, it's not on the screen, so it's a bad angle.
Okay, you may have to hold your head down. Okay, any comments or questions? There's another neuroradiologist on the panel, Luis Lopez-Ebor. Luis, do you have any comments or questions for Dr. Bai?
No, congratulations for the case. It's a very difficult case and important case because the AVM is associated with intracranial aneurysm. One question, Doctor. Your first case, parie-occipital case, a small AVM, the case is not bleeding. The patient is not bleeding, never, but in the control magnetic resonance control, you are a scar. I don't know why you are a scar. This is secondary to ethanol, or why?
Yeah, for that case, I use SNO obliteration for the nidus. To my knowledge, the SNO can destroy the endothelial cell of the nidus, so which can prevent the recurrence of the AVM. So at the acute phase, it will develop edema by the SNO, but maybe with couple of weeks, the edema disappear, and some obliterated tissue remained, just like, I think, just like something left after ischemia. So maybe it's a gliosis. So I say something like a scar inside the nidus, and beside the nidus.
Okay,
Maybe it's gliosis.
We have a question from a neuroradiologist from Russia, from Krasnoyarsk, Russia, Alex. He asks, what microcath did you use in the embolization of the infratentorial AVM?
Yes, for me, it depends. It depends on the size of the nidus. I often use a single microcatheter to inject the onyx because one distal tip of the microcatheter can guarantee a certain permeation range. So for a bigger size AVM, maybe single microcatheter is not enough. The other factor is depends on your embolic agent. If you inject the gluburon, when you inject one microcatheter will be disposed. But if you use the SNO, and no doubtedly you can use the microcatheter over and over again.
Okay, very good. Thank you, Dr. Bai.